Welcome everybody to this webinar where we're going to be discussing the value of rehabilitation and how to quantify this. We have three excellent speakers today who are going to be talking about their perspectives on this subject from personal experience. Before we get started, I'd like to give you a little bit about housekeeping. The webinar itself is going to be 45 minutes long with a chance for questions and answers at the end. When you look at the screen, you'll only see your name and the names of the panelists in the list of participants. However, please be aware there are many others who'll be online too. Your host will keep you updated via the chat stream throughout the event. If you experience any technical difficulties, and that's always possible, use the chat button on the webinar software to send an instant message to Kaylee. You can do that at any time during the event. If you have a question, and we'd love you to submit them as you think about them during the webinar, please submit them using the Q&A button on the webinar software, not the chat button. Please address your question to all the panelists so that they can all see it and think about their responses to your question. You can do that at any time during the webinar, and we'll try and get through as many as possible in the Q&A session. But we've had some beforehand as well, and we will post responses to those we don't get to on our forum. If you use Twitter, and we will be using Twitter throughout this webinar, join in the conversation. We will be tweeting even, at NHS-CSI. We'll be using #rehab and #rehabimprovers, all one word. Now in the slides today, there's an awful lot of wonderful information to absorb, but don't worry, we're going to record the webinar and it will go online with the slides in about a week after the event. We'll publicise the link on the Improving Rehabilitation Community of Practice forum and via Twitter, so you'll get to know when it's up and live for you to view. Without more ado, I'd like to pass you over to our first speakers, who are Tara Baohm, who's the Deputy Director of Strategic Delivery at Barking and Dagenham, Havering and Redbridge Clinical Commissioning Groups, and Carol White, Deputy Director at North East London NHS Foundation Trust. Many thanks to you both.
Thank you so much, Jane, and thank you very much for inviting us to be part of the webinar today. Carol and myself are going to do a little bit of a tag team today around a piece of work that we've undertaken in Barking and Dagenham, Havering and Redbridge. And we thought the best place to start really was where we started on our journey as part of this work. So just to give you a little bit of a flavour of where we were, what we had in Barking and Dagenham, Havering and Redbridge was pretty much a purely bed-based model of rehabilitation when we started. And we had 104 beds in our system. But what that meant was that for our patients, there was very little choice. There wasn't really a consideration around individual patient needs and how they could be best met. And there was a real lack of investment in home-based services. It also meant that our patients had quite long waits to get access to rehabilitation, so it was an average of 5 days to get access to a community bed. People went to hospital for entirely preventable reasons and quite often stayed in hospital longer than they needed to be. We had a very, very fragmented system, so every borough had a different pathway, which you can imagine was quite difficult for some of our acute trust colleagues trying to work out which part of a pathway patients were working through. And we had very, very long lengths of stay in our community bed units, so with an average of 29 days, but in some cases 40 plus, which wasn't necessarily the best outcomes for our patients. And we had highly variable quality across our units, and some of that too was on the basis that we had completely different service specifications for each of those units. But I guess most importantly for us as well was our patients were telling us the services weren't good enough in our patch, and actually things needed to change for them. So what we were hoping to do and how we were I guess looking at adding value was, one, to make sure we improved that patient journey and access to services, to make sure we improved that patient experience and outcomes for our patients, to look at how we supported most effectively our acute trust and make sure that flow and pathway was very clear, and also how we did all of this within the current financial envelope, which, as we know, in the current climate is a bit of a challenge. So this just gives you a little bit of a sense of what our system looked like, which you can see was quite complicated and messy, both from a professional perspective, but also our patients.
Thank you, Tara. So if you just refer back to the slide before, what you could see was that we had an overly complicated system locally, and what that allowed patients to do was completely circumvent where we wanted them to be and to go straight to emergency departments and go into an acute bed where they would reside for at least 21 days, then come to a general rehab bed for another 29 days. Meanwhile, their recovery was slow. And when you have slow recoveries, you have patients that don't recover as well as they should do in the beginning, and also they take longer to do it, so they cost more money whilst recovering. So that was the basis that we started our reconfiguration, to actually listen to what patients were doing, which was ignoring all of our points of access to the system because they were too complicated. So how do you make a system that works for the patient? You deliver it in the place that they know best, which is their home. Their home is the place that they're going to recover most effectively and stay well for longer. Meanwhile, the local authorities are happier because they are more likely to not go into residential care. So it's a win-win all round. So here is Beryl. Beryl just replicates any patient. It could be anybody. And really what we tried to do was think about how services could be delivered around that patient to maximise their outcomes. Because what we know is if you stay in a bed for anything over 72 hours, you're going to need more and more rehab. So it's a simple, effective way of delivering outcomes, but actually it works on a patient-focused level, but also on a financial level. So we went about thinking about service redesign, but actually to know that you've redesigned something that works, sometimes you have to test the model. It's not something we do particularly well in the NHS. What we do are pilots that we then decide we need to pilot again, rather than just saying it works and doing it. So we actually tried a different approach, was to say, let's double run. It's hugely important in the NHS to prove that the money you're spending is worthwhile, so it's very problematic to double run. But if you have enough evidence base and you can guarantee you're going to provide continued evidence, you will find that people will support that way of thinking. So we decided that we would maintain a bed base of general rehab of 104 beds for 3 boroughs, whilst also trialling 2 new teams. So the community treatment team, which is a crisis rapid response service, which will see patients within an hour and keep them at home rather than presenting them to ED, and our intensive rehab service, which is like rehab that you would have had in a general rehab bed, but within your own home. So we said, give us 6 months. If we can prove the case with lots of data and lots of outcomes, then after that, we think we'll be able to reduce our beds. But we're not saying you definitely can. We want to trial it. So that's what we did. And in order to count those outcomes, we had to do lots of data collection on a weekly basis. I became very grey through the period, but we were able to evidence what we were doing worked. So if we went back to our original system, we had 104 beds across 3 boroughs that had an average length of stay of over 29 days. We also could sometimes take up to 5 days to get a patient from an acute bed into one of our general rehab beds. So count the money. There's a lot of money being spent there on beds that actually didn't need to be spent. So we changed our system. We managed to start running down to a bed base of 52. So we were still being paid as a provider for 104, but we were only using 52 because of our average length of stay, our transfer times, and what we were able to prove, even with a reduced bed base, we still saw the same amount of patients in a bed, if not more. But at the same time, we increased the patients that we were seeing in their own home. So overall, we started with a patient journey of 1,300 in a year. And at the end of the services, we went to over 10,000. Someone's just asked the question, what do I mean by double running? What that means is we're going to do this, and that costs you £1 million to do normally, but actually we'll want to trial something else. That's going to cost you another £500,000 to give us the money to double run. So effectively, you're taking a chance. But the evidence that you use is that if you can prove your case by double running, sometimes it's called pump prime or other things that we say in commissioning. What it means is give me some money now to trial an idea, and then what I'll prove to you in the end is you will save that money long term. And what we did do was save that money long term. So some of the outcomes that I can talk you through is we were running on an average of 29 days average length of stay in our general rehab beds. That's now down around 19. And if you're being seen in our intensive rehab service, whilst we aim to get people well within 21 days, we treat it like a bed. Most people are well and discharged from the service in 16 days. And that's a credit, and what it shows is that if you get people out of an acute bed early enough, what they do is recover even quicker, so your savings multiply and multiply across parts of the system. Our readmissions to acute have improved, and that's primarily because if you're at home, you're less likely to have a healthcare acquired infection, which means you're going to stay well and you won't stay in a hospital bed for longer. So again, it's a self-proliferating idea, and the patients love it. And I think one of the things that is really key to this is our patients clearly didn't go to the services we wanted them to in the beginning. You saw that complicated system. Actually, what they want is a place that they can access when they want to. So what we did was design services that are self-referral, which is very, very key in terms of changing patient behaviour. If they're behaving badly and going to ED and you don't want them to, give them something easier to go and do. So they will self-refer to these services when they know that they need them. So that works for them. ED is an emergency department, just in case anyone didn't know. Why does it work? It works because actually it puts patients at the centre. It listens to what their journey is and what they need at the time they need it, rather than asking them to jump through lots of different hoops. And actually, if you get the intervention at the right time, then the improvements are quicker and more long-term. So overarching, you get system change for both the local authority funders and also health commissioners. So the success of those schemes allowed us to think further on how could we build on these. So I think key to the services, patients designed them because they told us what they wanted them to look like, but staff designed them. So we used an awful lot of QI, and we worked with agencies like the universities, and we had something called the Frailty Academy, which basically allowed frontline clinicians to say, okay, this is what we trialled as an idea, but we think this idea would work even better. So we came up with some more schemes, one of which was an in-reach service to our acute hospital. And again, what that allowed us to do is not wait for the acute hospital to refer to us, because they're very, very busy and sometimes they forget. We go in and now pick our own patients. The other idea that we had was working with our London ambulance colleagues, and some of you may or may not have good connections with your London ambulance, but certainly in London it's quite fractured in terms of how it's commissioned, and it was difficult to come up with schemes with them. And what this allowed us to do was give something that would work for them. They didn't want to convey as many patients to hospital, and we gave them an option not to. So it was about engaging on what their motivation is as well, and I think that's an important point on the how. You have to understand what people want out of the system, whether that's patients or providers or other parts of the commissioning system. So I think the rest of the slide speaks for itself.
So the next slide really, and we're asked this question a lot in terms of this piece of work, is very much the how. People are interested in how did you achieve and get these gains in terms of the difference and the redesign piece that we did. And this slide has a lot of information on it for you to reference, and there's a lot more information on our website as well. But just to pick up on a couple of key points for us. So this piece of work was very much embedded with a commissioner provider co-production approach, and what that means is we very much, both from a commissioner perspective, from my perspective and Carol's perspective, our two teams have very much been on this journey together right from the beginning. So right from the point where we looked at the review of the services and what we thought might needed to change, through to the development of the proposal, formally consulting on our changes once we knew we'd tested the model and knew where we wanted to go, through to decision and implementation. It's very much been us working together as equal partners on this piece of work, not a top-down commissioner-driven piece of work. So very much provider and commissioner together. And that also included some of our clinical colleagues, both from the NELF clinicians, but also our local GP clinical directors as well, having some joint conversations in order to inform the proposals. And for us it was very, very important because we knew we needed to change, because for those that don't know much about the BHR patch, we have a very, very challenged health economy. So we knew things needed to change and couldn't stay the same. I think the other piece that I'd just like to reference that was very important for us just briefly was how our patients were involved as part of that process as well. So right from the very beginning, in terms of developing our proposals, we were running focus groups with our local Health Watch colleagues to ensure that our patients were very much at the centre of those proposals and very much directed what it was they wanted to see from the new services. But also throughout the course of the trial, where we were testing the model, we were constantly getting feedback from patients around their experiences of the new services, what things needed to change, and how we could develop the services as we went along. So very much, very key have been patients involved in that process. But just the other piece that was quite key for us, and Carol has mentioned this already, was the evidence and data. You know, this absolutely was a test for us, and we had obviously a bit of a hypothesis that we thought this could work, but we absolutely needed to demonstrate whether it would or wouldn't. So right from the very beginning, we've been measuring the evidence and the outcomes, both at a patient level, at a service level, at a borough level, because clearly we're 3 CCG areas working together, at a whole of system level. And what I mean by that is how our system works together with the acute trust and other partners across our system in order to get outcomes. And the way that we went about doing that was we developed some bespoke dashboards in order to measure how our services were running. And you can reference on our websites, we have 150 pages of evidence in a decision-making business case. So the detail is all there for everybody's reference. And this is just a little bit of a summary of one of our dashboards and what that looked like. But as I mentioned, for more information on this piece of work, people are welcome to go to our website and or contact Carol or I directly.
And I'm just going to introduce you now Joanna Parris, who is the Programme Manager at NHS Future Focused Finance, Best Possible Value.
Thank you very much, Carol. Okay, I am going to talk to you a little bit today about our programme. Now, Carol and Tara Lee have very kindly given us a brilliant example of how they've decided in their health economy as to what it is they're doing, who's going to be involved, and how they're going to demonstrate and evidence what they've done in terms of patient outcomes. Now, in particular, proving it and evidencing it is quite tricky a lot of the time. And North East London have managed it fantastically, but if anyone's wondering how to do that a little bit more generically or how they can get involved, then our programme have some little tools that I'd like to introduce to you that you might be able to use to move along with that. And I'll just tell you a little bit about Best Possible Value. We are part of the Future Focused Finance programme, which is a 5-year capability programme led by the 6 organisations seen in front of you. So what happens is the Chief Finance Officers of Monitor, the HFMA and the Department of Health all come together every month and they say, okay, the NHS is under its unprecedented financial challenge. Demand is growing, but funding isn't. What are we going to do? And the obvious answer is that you've got a lot of finance staff in the NHS who are very skilled and very passionate and just want to know how they can identify best practice and start using it everywhere. So of those 6 work streams, we've got, for example, close partnering. My colleague Sanjay is going to be giving another webinar soon, and that's all to do with how clinical staff and finance staff can start talking to each other in a more sort of common language and start using each other's skills. They're actually quite interested in what the other does, so it'd be lovely if they started exploiting that relationship. I'm not going into too much more detail about Future Focus Finance as a whole. You can find out more at the website. I'm the Programme Manager for Best Possible Value. And now what we want to do here is change the role of the accountant. Somebody's got this idea that we're all grey suit wearing bean counters who love nothing more than being pedantic and saying no at the end of the day. We basically want to change that mindset. I have no idea where that stereotype has come from, but it's not true. In the future, we're all going to be called finance business partners. And the idea isn't to just sit counting the beans. We're brilliant in the NHS at counting things and collecting data and filling in returns and reporting. But we want to actually start using all of that information to inform decisions and in particular focus on getting value. So what we did as part of the work stream, we started out in 2014 by performing a survey and said, look, what do you struggle with in the NHS? Why is it difficult sometimes to get value? And 3 major themes emerged. One was a lack of clarity on respective roles and responsibilities, now particularly in complex multi-stakeholder decision-making. Since the Health and Social Act of 2012, the NHS structure in particular has got very, very complicated. And so a focus on value and decisions can really cut through that and people will know who exactly is deciding what. A narrow focus on the financial aspects of the options presented. Well, we think a focus on value can help that. And I'll talk a little bit about what we mean by value in a moment. In terms of the right information and right tools, we need to start, as I say, not only counting the data, but using it. Now, if you ask people what is meant by value and how we define value, they might give you a number of answers. They might say, if they're an accountant, oh, it's the 3 E's of effectiveness, efficiency and economy. If you ask a district nurse, it might be the 6 C's of care and compassion. A ward manager might be concerned with reducing waste. So that we can get everyone on the same page, we've looked to the work of Michael Porter. Now, you might have heard of Michael Porter. He's a famous economist and academic at the Harvard Business School. And he's spent a whale of a time over the last 5 years or so studying the American health economy and trying to come up with a common currency, if you will, or a common definition of what value means in healthcare. And it's characterised by this equation. I know half of you have already switched off because I put an equation up, but the other half are pricking up their ears because they love things like this. Now, 2 ways to increase value. You either improve the denominator of the equation, so improve patient outcomes, get those up, you'll improve value. The other way is, of course, to reduce the denominator and reduce cost. That will improve value. What Michael Porter's actually found and proved in practice through his sort of academic studies is that if you focus on improving outcomes and raising patient experience, clinical effectiveness and patient safety, lower costs just sort of drop out of the bottom as a bonus. So I want to use this definition of value just to get clinicians and finance all on the same page, talking about the same thing. What is it we're deciding? And our North East London example proved that perfectly when they started talking about patient outcomes in terms of recovery time, readmission rates, patient experience, winter resilience, reducing readmissions. All of that's fantastic. Those are things we can count. Those are things we can quantify, demonstrate and evidence. Talking about using this in practice, in reality that possibly means a group of 10 or 20 stakeholders sat around a boardroom trying to decide what it is they're deciding. So our tools largely involve popping it all down on a piece of paper. We ran a demonstration site in Liverpool CCG where they were trying to sort out lung health, obviously big inequality in Liverpool and a top priority for them. So they turned the value equation into this. Now, obviously we don't need to go into detail, but it gives you an idea. The criteria and objectives, what are we counting? Metrics, how can we count it? You get your clinicians and your finance people all around the table, and in those terms they can start deciding what it is they want to improve. This in turn comes to help you with options appraisal. Actually, if we've got 3 options, which is the best for our patients and which is the best for our finance health economy in terms of costs and expenditure? What are we getting out of this? And as you can see, if you start to rank things, use your red, amber, green assessments, you can start seeing which is first, second and third preference. Now the other part of this, we saw from our North East London example that everyone was quite on the same page and it was quite a rosy picture has been painted. I don't know if it happened in reality, but sometimes it's not clear who has the final say on a decision, especially in these complex multi-stakeholder scenarios we've been talking about. Things drag on, a group debates but adjourns without a decision, it escalates, somebody doesn't like the decision, we question the decision and may have the meetings about decisions. Liverpool CCG, our demonstration site, informally referred to this as the NHS decision washing machine. Okay, so their decision actually got stuck for quite a while in this washing machine and just kept going round and round and round. Now, one way out of that, apart from defining things in terms of value, just like North East London did, and measuring patient outcomes and quantifying patient outcomes, they found that the use of this thing called the rapid framework was really helpful. Now, Bain and Company developed this and we've borrowed it. It used to be called the RAID framework until the NHS got hold of it, and we realised that just because somebody's made a decision to do something doesn't mean anybody actually performs it. So here in this, you've got your stakeholders and you assign everybody a role. Everybody is clear from the very start, not only about what is being decided, how it's going to benefit patient outcomes, but also who is in charge of deciding what. Everybody gets a letter. Again, in practice, that means a big bit of paper. Again, we don't need to go into detail about what happened in Liverpool, but as you can see, we've got stakeholders along the top. There are a lot of them. There's patient groups in there, there's public health, there's our commissioners, there's our providing bodies, there's our healthy lung panel. Decide whether or not to improve lung cancer in Liverpool. Deciding would be the CCG. Agreeing that, the Healthy Lung Partnership Board, and recommending that, the Cancer Programme Group. So everybody is clear up front who needs to make the decision and when. So the benefits of using our best possible value approach is not only are we framing things in terms of value, which everyone can get on board up and which has been proved to be beneficial, it's about having good governance. You know who's in charge, you know when they're making the decision, and in 18 months' time, when it is questioned or if it is questioned, why was that decision made, how did you come to that decision, everybody's got a very clear idea of it. And a clear structured process. As I say, nobody wants to be stuck in the NHS washing machine. Please do go to our website. I've obviously given you just a really quick whistle-stop tour of everything that's available, but there is a whole process. There's some e-learning on our website by Bain & Company to teach you how to use these tools. Examples in practice, demonstration. We've also got signposting to our affiliates. By that I mean perhaps you might have heard of NHS Right Care. We are right on that programme. We are all involved in commissioning for value, and we fit really nicely into the basically how to get things rolling on that. If you're a bit of a numbers geek like myself, you'll be interested in the catalogue of data sources. As I say, what are we counting and how are we counting it? Please, with the NHS is very data rich. We have a list of everywhere you can get information. Similarly, in addition to the rehab community of practice, we have a best possible value community of practice. We've got a forum and blogs, and if you want to come and question either myself or any of our demonstration sites, just come and get in touch. We're very friendly and very approachable. Thank you very much.
Many thanks to all three of our speakers. We've had some questions come in during that session, some of which we are specifically focused on service provision, and I will get Tara Lee and Carol to respond to that via the forum at a later date. Thank you very much for those. We've got some more general ones which I'd like to start off with. One of them, the first one, increasingly services are working across the independent and voluntary sectors in a more integrated way. What can the NHS do to help quantify the value of integration? Who'd like to take that first? Carol, would you like to?
Okay. I think what we need to absolutely recognise is that there has been certainly historically a level of duplication across both the voluntary sector and providers from the NHS. And I think what that allows commissioners sometimes to do is to pick off some of the voluntary sector, because that's where local authorities have been hardest hit. So in order to support the value that they bring, what's very important is for providers to recognise what they do together and avoid duplication, and it's our role to support those discussions with commissioners. In some ways we are the bigger provider, so we need to support the third sector, which without we wouldn't be able to do some of the more qualitative aspects of our work. And as budgets are squeezed, it's important that we don't duplicate, but we actually enable each other to work as a fabric together, because they are part of the care pathway. So sometimes a preferred provider option can be helpful in that, because it allows you to very much place them as part of your care pathway as well.
Carly. Just to add to that, I guess in terms of how we quantify the value, it's very much for us about patient outcomes. So it's about how providers work together to deliver that holistic care that patients need to achieve the best outcomes. So for us, we're absolutely looking from that perspective in terms of the value.
We've got another linked question after that. We think that we are producing services of value in the voluntary sector. How do we bring them to the attention of the commissioners, and how do we start that dialogue? And I think that's something that all of us are picking up a lot more out there, that they want to have that conversation. How do we go about it?
So I think for us, we absolutely value the perspective and the services and contribution that the voluntary sector bring, and absolutely recognise that as an integral part of our system. So for us, we have some structures in place where the voluntary sector are very much at the table, along with other providers in our system, in order to obviously share their contribution and make sure our system is working together the most effectively that it can be, in order to get the best possible outcomes for our patients locally.
I think there's something around recognising the ability of the third sector to do things far quicker than the NHS. They tend to be able to be innovative in ways that we're not able to, because they have less governance structures for good reason. And what we can do as organisations, and part of our job as a provider of NHS services, is to provide that governance for them. So for instance, they may well want to get therapists within their teams. They will need a level of supervision. Something as simple as that will become quite complicated for a third sector organisation, because that costs money. Whereas actually as a system, if we agree that the governance structures allow us to provide that supervision structure, they can then be far more innovative, because they've got the backup of our governance structures.
We've got a question from the patient's perspective. How do we ensure we include the patient's perspective in measuring value of services? Again, I think that's for you, Carol and Tara Lee, to...
I guess you listen to them, ultimately. And if you listen to them, what you start to understand is what's important for them and how they behave, and therefore how you need them to behave to make your system work, which is, if you're in a difficult system like we are, you need them to behave in a way that allows the system not to overuse emergency departments. So you have to understand why they're doing that in the first place, which if your services aren't up to scratch, you need to change them. So I think, number one, listening, and then using your clinical outcomes, so value-based tools, but also evidence-based tools from a clinical perspective, so that you can evidence what you're doing is actually achieving them. And sometimes patients don't always want that. When we looked at reducing our bed base, there were some patients who don't want to be treated at home. But what you have to do is present them with the evidence that says being treated in hospital isn't as effective. And if you give them the information, then they can process that rather than just they assume it's about closing beds.
So very much about working with the patients, the people who are going to be using your services. Charlie, anything to add to that?
And just to add the value, I guess, from the perspective of the patient, we mentioned through the presentation, patient feedback was absolutely integral in terms of how we developed our services locally. And I think it's probably the strength of that work in terms of that engagement, which has meant that the patients and our local community have developed a confidence in the services, which therefore has seen, as we referenced in the presentation, now over 10,000 patients seen in comparison to 1,300. So when you're seeing quicker access, more people can get access and better outcomes, patients recognise that value as much as we recognise the feedback in helping us achieve that.
Thank you. Now on to some questions which are around the finance aspects. And somebody's asked, what can I do if my finance team won't engage with this initiative? Jo, you talked a lot about how approachable you are, but what if they're stuck in that position? What would you suggest?
I think it's very unusual for a finance team to be disinterested, shall we say, in assisting with designing better services. A couple of surveys have shown that quite the majority of NHS finance staff are actually working for the NHS because they want to help improve services and because they want to feel closer to patient care and feel like they're making a difference in helping. So I'd say in terms of, I wouldn't say you needed to even evidence to finance that this is a good thing to do. I think they're the ones who can actually help you gather the evidence to prove to everyone else it's a good thing to do. I'd get them on board at the beginning if you can and say, look, we've got the tools, we've got the information, we can really do this. Can you help us?
Okay, also leading on from that, would you suggest when we're discussing risk or best practice, we should invite our local finance guy?
Absolutely. As I say, they've got access to a lot of information and brilliant skills, particularly in terms of risk and decision making. Get them along as soon as possible. I know sometimes the finance department can be a last resort and, oh, we'd best pass this over to them. They'll just say, no, it costs too much. But as I say, finance is changing. We're not just sat in the back office anymore to slap wrists. Get finance involved as soon as you can because they really can be helpful.
And from a provider perspective or commissioner perspective, would you want to add to that?
I think I would just echo the perspective that do engage your finance colleagues early. Certainly working with finance was quite key for us in terms of getting to the point of final decision where our service model was agreed, and it was agreed that we would embed the new services locally on a permanent basis. So this wasn't a case of us and them with us. This was us all working together as a team with our finance colleagues in order to achieve the change that we desired.
I think I would just add, I think what can help is understanding a common language. And I mean that no disrespect to finance colleagues, but they will have an agenda and a way of understanding the world, and a clinician will have a different way of understanding the world. And what's important is to come to a common frame of understanding. So if you're going to measure something, how are you going to measure it, and how does that work for both colleagues? So a simple measure of bed days. It's a very simple thing, but not necessarily every clinician is going to understand how you count bed days, but actually that will be very important to your finance person who can then work up some financial analysis around that. So I think, and someone may need to assist somebody in getting that language, but actually it's very helpful.
To engage and get that partnership and the common framework. Yes, absolutely. One other question we've had, which links again to this, is that rehab services and the leaders of those services are often so embedded that they're hidden within a larger system, which is really quite tricky for them. So if everyone is knocking on the doors of finance departments and there's some sort of pecking order, how do we, the rehabilitation services, make the case for finance to work with us in particular? We'd like to answer that first.
I was going to say, know your worth. If you actually look at the ability that therapy has in general to support your acute colleagues, it is huge. They would fall down without the services of rehabilitation. Probably 60% of their flow goes through a rehab bed. So if you start with understanding your importance, you then have a very good case for making some changes to what you want to do.
Aurelie, anything else?
No, I'd absolutely echo that, and just the change that we've seen in our system as a result of making our out-of-hospital rehabilitation services more robust has just been incredible. So I'd absolutely echo that.
Yeah, and Jo, any comments from you?
Well, yeah, absolutely. I completely agree. It's about this common language, isn't it, and proving your worth. Also, I'd say it doesn't have to be that formal. There is talk of perhaps a guerrilla approach to changing mindset. You know, a casual question here. Oh, what is it we're actually trying to achieve here? What is it we're trying to decide? Oh, do you know who's actually got the final say on that decision? So it doesn't have to be all or nothing with your finance department. Relationships aren't built overnight. Please do just go and make contact with them. First step is always the hardest, but once it's there, it's done.
Thank you for that sound advice. One final question at the moment, and we've got one around how do you find the best person in commissioning to get in touch with if you have no experience of contacting commissioners? And I think a lot of people come up with this comment when we're talking to people out there in the wider system. So I think really that's for you, Tara Lee, if you can respond to that one.
Yeah, the how-to can be quite tricky actually, because each system can be quite different in terms of their structure and their setup. I guess what we had the advantage of locally is we had a very, very strong leadership group that very much led the vision and the strategy for our piece of work. So we had the buy-in at a very, very top level, which then obviously supported us, Carol and myself, in terms of delivering the change on the ground and all the associated work that needed to go along with that. So I would look, I guess, in your system for someone or your leaders that might have a particular interest, people that you might be able to advocate to. I think don't be naive in thinking that systems will have just one commissioner in the current system that is responsible for rehabilitation. Quite often it's split across a range of roles. So I think we need to be thinking about there might be a range of individuals that you might be able to tap into in order to promote the case for rehabilitation and maybe promote the case for some change in local systems.
I would just add know what their motivations are. If you can work out what somebody's motivation is in the system, you're more likely to tap into what they want. So most commissioners will be struggling with acute costs. So actually, if you can provide an evidence and a good sound basis that you will start to drive through change from acute and care closer to home, you're likely to get their ear very quickly.
And presumably, Jo, from your perspective, you'd be able to support that, wouldn't you, in terms of giving them the help with the evidence?
Absolutely. Again, using the value equation, the criteria, the metrics, the data sources, and even just, as I say, going asking your finance person, hey, do you know who in commissioning I need to speak to about this? Can also be very useful.
And Carol, we were talking earlier about finding people within the provider system, similarly, who might have rehabilitation as something that they might be interested in, going out and finding those individuals to champion this idea.
Absolutely. I mean, I think if your direct line manager or your line manager's line manager is not necessarily championing a rehab, given the evidence base that we have of how powerful it is in terms of the individual's recovery, but also supporting the system economics, you need to find someone who will listen. And that could be someone like your clinical leader for therapy or an OT lead or a physio lead, because those people will have within their job description the need to champion evidence-based practice and will challenge your provider, who is your ultimate manager, about the delivery of things. I think if the person that you're reporting to doesn't recognise that things can always change and get better, then find someone who is prepared to have that conversation with you.
Thank you very much indeed. That's all we've got time for in terms of questions. Just a couple more things to let you know. We want to make sure that you're networking actively. It's up to you to do this, to find other people who've got a common interest with you and share your passion. Do follow us on Twitter at NHS-CSI. We will be trying to signpost information that we find and ideas. You can do the same thing. Use #rehab or #rehabimprovers when you're doing that so that we can all connect up. There is also the Community of Practice Forum on NHS networks, which will provide information, give you access to larger pieces of documents, and you can post on that forum if you go to that first link. Become a contact. We can send stuff to you directly into your inbox. Follow the second of those two links and go to point 4 and it will tell you how to do that. NHS networks can be a little bit difficult to navigate on occasions, but don't be put off. You'll get there. And finally, we have 2 other products you may be interested in. Jo talked about the up-and-coming vodcast, which is the second of those 2, available from late February, around clinicians and finance teams working together to quantify the value of rehabilitation. And that will help you if you've had some ideas coming out of today's discussions that you want to pursue. You'll get more information within that vodcast. And the first one there is one that's available right now on YouTube. That's a commissioner describing from her perspective the benefits of commissioners working with service providers to develop rehabilitation services and how that can support her objectives, but also some of the challenges involved in commissioning rehabilitation. We mentioned earlier the issue could be that rehabilitation could be in all sorts of people's portfolios in all different places and needs to be sought out. Lindsay Hughes from NHS England also gives a broad overview of the current Improving Rehabilitation programme. So without more ado, I'd just like to thank all our speakers today for a very, very interesting discussion and for all the information they provided us. You can contact them, the details will be on the slides, and we will be giving more information on the community of practice for people to follow up. But do get in contact with each other via Twitter or via the forum. Thank you all for listening.